Welcome back, everybody. I hope you had a good lunch. Normally, the lunchtime sessions are in small, crowded rooms. We all get together, but there was so much space up there. We were spread out, so there wasn't quite as much chat. But there was a lot of good chats on the individual tables, I thought. But we're now going to kick off with the afternoon session, which is much more patient-orientated for the first part. And the first speaker, Prof Henrik Frederiksen, who's come over from Denmark. I'd like to claim he even moved his son's wedding a week earlier so he could make it here, but his son's wedding was last week. This is to escape. Denmark is one of the few countries in the world that develops nationwide good health outcome data, and he's published widely in some of the problems with ITP and effects of steroids, fatigue and issues like that, plus other conditions as well. But I was particularly keen to get him here to chat, particularly to set the scene as part of this afternoon session. So I'm really delighted that he was able to come over here, and I'm really looking forward to hear what he has to say. Henrik, thank you very much.
Thank you. Thank you very much, Adrian. And I must say I'm a bit humbled to be here to speak about quality of life at a patients-oriented conference. I'm not really an expert. I think most of you in the audience are the real experts in this field, but I'll try to show something about the research that has been done in this area and also some of what we have done. So these are my disclosures. You heard previous speakers talking about definitions in ITP, and luckily, or I don't know how to phrase it. Anyway, it's a good thing that ITP description is now changing from just being a bleeding disorder in how we talk about it, instead being now a bleeding disorders also with fatigue and reductions in health-related quality of life. Of course, it's not new, but it's good that it's also how we phrase it. It's been mentioned previously that also some of these studies have been mentioned that there hasn't been a lot of health-related quality of life outcomes in the clinical studies that has been done so far, but it's increasing. And in the guidelines that Cindy also mentioned, with more recent guidelines, there is more and more mentioning of quality of life domains, issues that clinicians has to be aware of when managing patients dealing with treatments, etc. Many of you may have participated in this nice and very large survey, the IWISH study, 1,500 patients from across 13 countries, and patients participating in this survey were asked to assess the burden of their symptoms at the time they completed the survey, but also try to remember the burden of the symptoms when they were diagnosed. And there were some years between that, or time between that. But anyway, what is striking here is that at the time of diagnosis, many patients have a lot of bleeding symptoms. You can see that to the right. And at the time of survey completion, luckily most of the bleeding symptoms has decreased, or the burden from them, but the points that I have marked with red arrows, the symptoms like fatigue and anxiety, depression, stays unchanged. So these are issues that are not particularly well dealt with in follow-up of patients with ITP. I've looked through some other studies, and there are some cross-sectional surveys, including more than 3,000 patients, and those have been compared either with within study comparators, or sometimes with population surveys, and they've used different tools, and that's a thing that we can discuss later on if you wish. There are different tools of measure, how to measure quality of life. I mentioned some of the frequently used ones like the SF36 and the ITP-PAC, and every single one of those studies shows that patients with ITP have health-related quality of life reductions compared to general population persons. This study is very frequently cited. I have to remind you, it's a very small study from California, including, I think, 83 patients from a referral center for ITP. So these patients may not be typical for, so to speak, an average ITP patients. But anyway, these are the health-related quality of life scoring in this SF-36 system. The yellow line are patients with ITP, and the other lines are either general population persons or persons with other chronic conditions. And the patients, the ITP patients, score the lowest, or at least at the bottom of the scoring, comparing to other chronic conditions like cancer and other chronic conditions. So these patients are not feeling so well. What are the determinants? It's been said frequently already that fatigue is really a major driver of reductions in quality of life in ITP, as it is in other chronic conditions, I would add. But also there are some specific themes that are important for patients with ITP, and that's of course fear of bleeding, it's anxiety, depression symptoms, it's the bother of the disease, the unpredictability, and also some of the effects from treatment, and particularly side effects, of course. Absences from work and school are a major driver also in health-related quality of life reductions, and reproductive issues are also reducing quality of life. What about platelet counts? This is a survey again, here illustrated, participants in this survey separated by the platelet count when they completed the survey, and I just highlighted those with a very low count, below 10,000, and those with a completely normal count, above 150,000. And in this system, the ITP PAC, higher scores means better quality of life, and as you can see, there are major differences. People feel much better when they have normal platelet counts. Steroids, we heard about them already. They are famous for their high response rate, for their low price, and also infamous for their large amount of side effects. And this particular study, they asked patients about all the types of side effects that steroid can cause, and how many of them would rate them as causing a lot of bother. And they also asked doctors, not the exact same doctors, but doctors, how often would they think their patients were bothered a lot by a particular steroid side effect. And patients are the orange columns, and doctors are the yellow. And as you can see, there is there is a disconnect. Doctors are not fully aware of the amount of bother that steroid side effects causes their patients. There is only one single item that bothers doctors more than patients, and that's high blood sugar levels. Burden of fatigue is considerable. Adrian and Quentin, I think, wrote this very nice paper some years back in the British Journal. It is, as I said, it's among the worst scoring quality of life domain. It leads to absences from work. There are maybe some news there, but when I wrote this slide, there is modest improvements or no improvements with the available therapies. There may be new stuff coming out, and the causes are for sure complex, but Dave said something about inflammation. I fully agree with that. Okay, I'll talk a bit about what we have done in this field. I'll just give you a very, very brief introduction to how this is possible. In Denmark, we have a variety of health registries. We linked some of those to do the research that we did. We can do this because all healthcare delivery in hematology is public, and there is a registration of almost any health event in hospitals, and also other registries. So we linked some of these registries to do the research that we do. I'll talk a bit more about that. We have the Danish National Patient Registry ongoing since the 70s. It registers all hospital contacts for whatever reason patients were there with a diagnosis, and we use that to identify both patients and also their comorbidity and outcomes. The Danish Zero Registration System is the backbone of all that. We have the cause of death registry and a national prescription database from 1995, registering all reimbursed prescriptions, and also a cancer registry. I'll not talk about cancer today. So we use that to construct a cohort of patients with ITP and some comparators, and followed them with their medical history before the start date, which was the diagnosis of ITP for patients, and assigned index date for comparators, and follow them to any event. In this case, I'll be talking about mental health. The numbers are not completely correct. We updated the registry, so the number of patients is more like 7,000 nowadays, and the comparators equally increased. So this is how we do the results that I will show you now. This study is on mental health outcomes in patients with ITP. So you can see a lot of graphs on your right, and the purple lines are patients followed from their date of diagnosis, and the green lines are their age and sex matched comparators from the Danish population. And in this study, we followed them for hospital-registered psychiatric or mental health diagnosis. And as you can see, the purple lines are above the green lines for depression, anxiety, and OCD, and also fatigue now being registered as a hospital diagnosis, indicating that patients do have some mental health issues following their ITP. We also try to see when this happens, and if it's equally frequent for men and women and across age groups, and it was equally frequent, and most of the trouble is in the first year following diagnosis, but for conditions like anxiety and OCD and fatigue, these are the bottom ones. There's a pointer here, but the two lower ones, the risk stays elevated even 10 years after diagnosis. These were these were events registered only in hospital. We do not know anything about what's going on with the general practitioners, but we can track that using prescriptions. And here we have psychotropic drugs prescriptions for patients and comparators before and after their diagnosis. And you can see anxiety drugs like benzodiazepines and antidepressants are increased for patients, and you can see that some of them actually are increased before diagnosis, probably indicating that they're not feeling well for whatever reason, and doctors may misdiagnose it as mental health conditions with probably just being symptoms of their ITP diagnosis. It does not apply to antipsychotic drugs. Right, so when we want to treat ITP, you heard a lot about that already. I'm not going to take you into details about that, but one of the things we really want to do is also to optimize health-related quality of life. The first thing is that we learned the first day in medical school is to do no harm. It sounds easy, it's not so easy all the time, but we should really strive not to do that. Then we should use, of course, tolerable treatment that works. We should discuss patients' preferences with them when prescribing a drug using shared decision making, and then we should of course also manage whatever complications and comorbidity may affect quality of life, or at least refer patients for other health professionals to do that. There are some studies, and you heard some of them mentioned already, or the compounds that have shown that health-related quality of life can indeed improve with treatment. This is ITP directed therapy. You know, we've talked about L-Trombopac already. The pivotal trial, the RACE study, showed that the SF36 domains increased scorings for quality of life, increased much more for patients treated with the active drug compared to those patients that were randomized to placebo in this study. This is after half a year of drugs. Pretty much the same result for the other TPO at the time. Romiplastim using a slightly different tool to measure quality of life, but many domains were much better dealt with for patients receiving TPO compared to patients receiving a placebo. The interesting result after this study was also another study that Dave did on patients treated with romiplastim compared to patients treated with other platelet elevating therapies. And in this study, quality of life improved for both patients receiving romiplastim, but also those that had a standard of care. But when they broke it down by response, the major improvements were really seen amongst the patients treated with romiplastim or a standard of care treatment that responded to the treatment, probably not unexpected. That was then, as Dave also mentioned, nowadays we have the upcoming rilzabrutinib compound. It's not yet available, but the results are really interesting. It's also a placebo-controlled trial, and this study shows you some results of the fatigue scorings, and the upper line shows patients treated with rilzabrutinib, and the lower line those receiving placebo, indicating that fatigue improves for patients receiving the active drug, and not so for patients treated with placebo. Not unexpectedly, you would probably think. But the interesting thing here is that patients that did not meet the primary endpoint in this study was platelets above 50,000 for the last 8 measurements, also improved there. Despite not meeting the endpoint, also improved their fatigue scorings, not to the same extent as those that responded, but there are some interesting results here. This was not seen in patients treated with placebo. Which brings me to my conclusion. I think you're well aware already before listening to my talk, that health-related quality of life reductions in patients with ITP is considerable. We've shown that mental health is also affected, at least in some patients, and the causes are complex. I didn't show you anything about that. We really need some prospective data, longitudinal data from patients in routine care, and not only, those in trials or those that we do a survey on. But what we do not know so much about yet is how to manage health-related quality of life reduction best. Is it a ITP-directed therapy? Is it psychosocial support? Is it e-tools? I think there's a lot of things that needs to be studied better, and I'm sure the next speaker will talk about some of the issues, and I'm happy to hear your views also. Thank you.
Any questions for Henrik?
Yes, I could throw something in. Thank you, Henrik. And what I wanted to throw into the equation was the impact that the various drug treatments we have on our quality of life, on our sort of mental health, and how we adjust to them along the way, kind of take them on board. Particularly, obviously, the steroid aspect, I'm sure everyone will be familiar with. But mycophenolate mofetil, rituximab have difficult side effects at times. From personal experience, that they did the trick for me, but they did other tricks as well. So I'm sure others will empathise with some of those issues. Perhaps you could kindly expand on those for us. Thank you.
I didn't quite get the question.
Yeah, what we're saying is that a lot of the treatments themselves cause you difficult mental health issues and quality of life issues as well. For example, steroids and mycophenolate.
Yeah.
You don't get much sleep on either of those.
No. I fully agree. There are a lot of side effects to consider for any type of treatment. We do not know a lot about if we want to study it in a systematic way, how much reductions in quality of life it costs, but any treating physician can, of course, learn from their patients that any drug has a severe side effect in that particular person. And of course, you have to deal with that first and foremost. Yeah, that's a good point.
Okay, any other questions? Thank you very much, Henrik. Thank you. Right, the next speaker is a gentleman I first come across last year. We did a patient meeting with the haematology team at Liverpool University Hospital, and this chap, and he's no relation, Dr. Andrew Morgan, a clinical psychologist, did probably the best presentation I've seen in recent times on the psychological aspects of living with ITP. It was so well received, and I believe there is a patient here who was, a young lady at the back there, who was actually at that meeting as well. And I heard you was praising it up as well earlier, so thank you. And Andrew is going to talk about the psychological aspects of living with ITP. What I would also add is that Andrew's also kindly agreed to work with myself and Adrian, and we're going to try and pull together a series of patient virtual meetings for the clinical, the psychological aspects of ITP that will take place later in the year. So watch the social media, watch the website for that. That is coming soon. Andrew, over to you.
Thank you very much. What an introduction, that's not Listen, lightning might not strike twice, but I will do my best to deliver something at least a little bit interesting. Hi everybody, my name's Andrew. As was said, I'm a clinical psychologist. I work at Liverpool Royal Hospital in the haematology department. And I'm here today to talk about managing stress with ITP. What I'm not here to talk about, to echo what Henrik said, I'm not here to tell anybody what to think or how to feel or what they should do. You guys are the real experts in living with ITP, supporting people who are living with ITP. What I'm here to talk about is some of the things I've learned from my clients during my time doing this work, some of the things I've read in the research, and some of my own reflections on this experience. I'll say as well that Henrik did preempt a fair amount of the stuff that I'm going to talk about, which is reassuring for me because it means I'm not just making it up. My hopes and expectations for today are that maybe there'll be one or two perspectives or ideas that you might hear that might be of help to you. One of the things with psychology is that whether you're dealing with a chronic health condition or bereavement or trouble at work, what have you, stress on some level is stress, and the effect it has on us and the things that are helpful will be generalisable. So even if there's nothing here that you particularly think, well, I could use that, there might be someone in your life who's facing a major challenge and you could pay it forward perhaps. If at any point you need to leave, stretch your legs, go for a wee, whatever, feel free. I promise I won't take offence. My first thought when I saw the plan for today was 20 minutes, it's not a very long time. So I've got to pick one big idea and do a deep dive on that. The idea that traditionally I've had the best feedback on from doing these sorts of things is called the stress bucket. And some of you certainly have heard me talk about this before, and a lot of psychologists do use this metaphor. But yes, as I say, we'll be able to go a little bit deeper on it in the time that we've got. And then at the end, I'm going to talk very briefly about ideas for additional psychological support for people who feel that might be of help to them. So what is the stress bucket? Imagine that each of us has inside ourselves a bucket that represents our ability to tolerate stress or distress. Maybe different people have different size buckets based on their upbringing or their genetics or what have you. It doesn't matter. Everyone has a bucket, everyone has a limit to how much stress they can tolerate. No one can take an unlimited amount of stress. However, obviously life doesn't care about this, and it will keep pouring stress liquid into our buckets. Comes from a variety of different sources. You might have a pint of water poured into your bucket because your car broke down on the way to an important hospital appointment. Or a massive jug of orange juice because you just got some bad news at that hospital appointment about your ITP. You might have a thimble of milk poured into your bucket because you went to the fridge to make a cup of tea and there wasn't any milk, someone had used it all up. Wherever that liquid comes from, it all mixes together in the bucket and adds to the cumulative level of stress. When that stress hits the rim of the bucket, it can spill over, leaving us feeling overwhelmed. One of the things I like most about this metaphor, and why I use it so much in my clinical work, is it captures this idea that stress is cumulative. The straw that breaks the camel's back, that pushes us over the edge, as it were, need not be the biggest stressor in our lives. There's been a few times in my career where clients have kind of come to me and said, Andrew, I went to the fridge to make a cup of tea, there was no milk left, I burst into tears, I think I'm going crazy. And we'll talk about the stress bucket and we'll understand together that we can only make sense of their experience if we also respect the fact that their bucket was 95, 99% full when they woke up that morning, because they're dealing with ITP, physical health issues, they're dealing with their mum not being well or having bills to pay or whatever it is. When your bucket's nearly full, it makes the little things in life that much harder, things that might normally be water off a duck's back. One of my messages for today is that if we can be aware of the sorts of things that are particularly stressful for us, the signs that we are becoming highly stressed, potentially overwhelmed, and the things that might be helpful to either deal with feeling overwhelmed or, even better, to deal with stress before it reaches that level, then we can get on the front foot. We can make plans, we can take proactive action, rather than the feeling a lot of my clients report, which is this sense of being on the back foot, just dealing with life as it's flying at them, almost too fast for them to react. And to this end, what I'm going to be doing is I'm going to be posing a series of rhetorical questions to you. And my suggestion would be, if you're interested, to make a note of those questions. I've sent the slides over, I'm sure they're available on request. And then when you've got 15 minutes over a cup of tea or similar, just have a little go with pen and paper and write down some answers for these questions for yourself. Some of this stuff might seem on the face of it self-evident, something else I hear a lot in my work. However, I would point out the difference between being able to sit down in the cold light of day and think of an answer to a question and having it right at the top of your head for when you need it, when the chips are down and the stress is really high. The first thing that goes when we're overwhelmed is our memory. So if it's up here at the forefront of your mind because you made a list of it or what have you, it's much more accessible. Okay, so the first rhetorical question, what fills your bucket? Again, I'm not saying anything that people don't either know from experience or have heard today, but for my work, number one with a bullet for most of my ITP clients is fatigue. Fatigue is an absolutely terrible thing when it comes to stress because it has a multiplier effect that makes everything more difficult. That emotional, physical, mental, spiritual exhaustion that comes from fatigue makes our emotions much more labile, up and down. Makes it harder for us to do the things we care about. We'll talk in a minute about how stressful it can be to turn down opportunities or say no to things that we want to do and that are meaningful in our lives. Treatment side effect are another massive one, as everyone knows and has spoken about. I think one of the things that makes it so psychologically challenging for a lot of my clients is the kind of paradox of I'm taking this thing because it's supposed to help me and actually it's making me feel worse. A sense of, if not unfairness, it just kind of doesn't make any sense. Things like nausea, weight gain, picking up other illnesses, infections because of a suppressed immune system, that sort of thing. Medical events, by which I mean things related to healthcare, so appointments. One of the things that makes ITP so challenging from a psychological perspective is the unpredictable course of it. People can be on a treatment that's been working well for a while and suddenly it stops working so well and people don't know why. It's not something that can be explained and then we've got to start a new treatment with all the uncertainty that brings along with it. As I mentioned before, having to say no to things, that's a massive stressor for a lot of my clients and is represented in the research too. How much time can I take off work before people get fed up? How many times can I turn down a social invitation before people stop asking? How many times can I not go for a walk or do this other thing that's important to me before I don't want to do it anymore, I'm not able to? And then last but not least, everything else in life. As if life wasn't hard enough already, even without ITP, I think for me, the number one rule of psychology is life is very, very difficult. People feel stressed because life is stressful. And that's one of the reasons why I think anxiety, so-called depression or low mood, are such a common factor when we see in the research, because they're, in my opinion, most often a normal, natural response to the hell of a challenge that we face with living well. Okay, next rhetorical question. What does an overflowing bucket feel like? I would suggest that feeling overwhelmed is a pretty much universal human experience. I'd wager almost everyone in this room has felt overwhelmed at some time in their lives and will do again. But how it feels for people can vary. It can vary between people, or maybe within one person in different days, or even across the same day. It could feel like anger, that red mist, or irritability. It could feel like sadness, feeling tearful or blue or low. It could feel like anxiety, being jittery on edge, that sense of dread that something terrible is about to happen. It could feel like being numb, not feeling anything at all, feeling flat, unable to enjoy something, or unable even to feel sad about things. And it also could feel like exhaustion. One of the things I was referring to before when I said about getting on the front foot is, it's one of the truisms of psychology that a lot of the time we notice how we're feeling emotionally and in our bodies before we notice anything else. How many of us haven't had that experience of rattling around our homes, being irritable and being rude to our loved ones, and suddenly thinking, hang on a minute, what's wrong with me today? Why am I acting like this? And that's when we sit back and think, oh, it's because I've got this appointment coming up, and this thing didn't go well yesterday, and I didn't sleep well, and I'm feeling sick, and all the rest of it. So we get to know what some of our common patterns of feeling are. It can be a brilliant way to cut stuff off before it gets out of hand and start to engage our helpful coping tools, which we'll talk about in a bit. What kind of things help when we're feeling overwhelmed? So when the bucket's spilled over and it feels like our head's about to come off, number one for my clients on average is what we refer to as time and space. It's deliberately ambiguous. It's like asking how long a piece of string is. It's whatever you need it to be. It could be 5 deep breaths before you respond to someone. It could be taking 10 minutes out to go into another room, make a cup of tea, go and stand in the garden for a bit. It could be sleeping on a problem and coming back to it the next day. Whatever the case is, all these things share one big idea in common, which is if we remove ourselves from the thing that's triggering for us, literally and metaphorically giving ourselves time and space from the problem, it allows our physiology, our minds and our bodies to come down just a little bit, take the edge off, and then we're able, as I said before, to think much more clearly, make decisions we're happier with in the long term, we don't regret. Sharing with loved ones is a big one for a lot of people. I'll always say at this point that I would never want to stand up here and make anyone feel like if they didn't share with their loved ones or they didn't want to talk about their problems that they were doing something wrong, because I don't think that's the case. I think for a lot of, well, not a lot of people, but for a section of people, this is not particularly helpful. I'm one of those. I don't like talking about my feelings, which I know makes me a massive hypocrite given my job, but there you go. I find it quite stressful, so I'd rather not. But for some people, for a good chunk of people, this is a massive help. A problem shared is a problem halved, they say. Rest is a big one, easier said than done. As I said before, saying no to things is a major stressor. So rest, giving ourselves that time when we notice that our bucket's overspilling, can be a stressor in and of itself. However, as many of you will be aware, there's this idea in psychology and in physical health that if we do try and push through on a given day and get our to-do list checked off, even though we know we're kind of on the edge, what might happen is the day after that, we're just laid out. And in the end, we end up getting a lot less stuff done. However, if we're able to take that rest when we need it, the day after that, on average, we get more stuff that matters to us done. That idea of a marathon rather than a sprint. And then the last one I've got here is self-care. Self-care, the idea of committing a conscious act of kindness towards yourself. This will vary between different people. Maybe it's a long hot bath, maybe it's a beer, maybe it's something nice to eat. Maybe it's going to bed early with a book or staying up late to watch a TV programme you're enjoying. The key thing psychologically is making that conscious effort to say to yourself, you're worth looking after. this is a reward for you because you're doing really well in a difficult situation. We're so quick in our culture, from my experience, to put the boot in on ourselves, emphasise where we feel we've let ourselves down. It's much harder for most of my clients and for myself to do the opposite. So making a conscious effort to do that is often necessary. Next rhetorical question. I painted a bit of a grim picture in some ways about life. It's hard and it's stressful, and we're hanging on by a thread sometimes. Here's some of the good news, right? Which is that our buckets have a tap on it. There are things that we can do that can reduce our stress level before it reaches the point of tipping over. Some of the big things here, on average, are things like social engagement. I said before, talking about your feelings isn't for everyone, but in general, you could talk to people, connect with people, and not talk about your problems. You talk about the football, or where you're going on holiday, or what they've been up to. A lot of people generally find this to be de-stressing and an important, meaningful thing in life. Any sort of social connection, whatever fits with you. Being present is a massive idea in psychology. That's this idea that we're tuned in and aware to what's happening around us in the here and now. One of the major things I didn't talk about today, but I would normally, is this idea of worrying being a source of stress. Worrying or thinking about the past, it's like going into our mental simulators, our imaginations, thinking about things that might go wrong in the future, remembering things that did go wrong in the past. It's an infinite source of stress, because you can spend, I've got clients who spend hours a day in that world, and nothing's achieved. It just adds to the stress liquid. The opposite of being in that simulator is being present and engaged in the moment. My favourite example of this is someone who's watching TV or reading a book, and they're staring at the screen or the page, but they're thinking about their problems, and so after 5 or 10 minutes they realise they've got no idea what's been going on, right? That person not only has added additional stress to their bucket, but also they've missed out on something that could have been enjoying or exciting or relaxing or satisfying. The ability to notice that and then tune in to say, actually, what is going on in this story? What is going on in this page? Is a tremendously powerful thing. I realise a lot of the stuff I'm saying, as I say to a lot of my clients, psychology is simple. It doesn't make it easy, right? It's not a switch you can flip on and off, but when we're consciously aware of this stuff, it's much easier to notice it and then take steps to start to practice these sorts of things. Doing what matters. I come from a school of psychology which tells us that doing what matters, having a life full of meaning, is the whole point of psychology. It is literally the meaning of life. So, classic areas of meaning for people, things like social connection, occupation, hobbies, projects, nature, spirituality, physical health, all this kind of stuff. I always think at this point, the last thing I want to do is give people the impression that meaning in our lives has to be some grand, big gesture or thing. Meaning for me exists on a spectrum, from the big things like the people that you love or the projects you're working on, all the way down to stuff like, for some people, a sunset, or that first hot drink of the day, or sitting in the garden admiring that work that you did on the weekend, whatever it is. Those moments of presence that I mentioned before. And I'll say to a lot of my clients, and they report to me, and it's helpful, when they have a list of some of the things that they care about and that are meaningful to them, then they can be proactive and plan their days around that kind of stuff. I've got a client at the moment off her own back, put up a bit of flip chart paper or whiteboard in her bedroom, and she's got some stuff on there that she generally finds meaningful. Smaller things like washing her hair or doing 10 minutes of yoga in front of the TV, or enjoying that cup of tea with the phone in the other room. And when she wakes up in the morning, she'll go through, pick a couple off and say, right, that's my aim for today. If I don't get to them, that's fine. If more stuff happens, that's fine too. But it's an example of proactively structuring our lives around meaning and purpose, rather than that reactive mode of, I'm going to get out of bed, walk out into my house and just kind of see what happens, as so many of us often do. Okay, so the last slide, I mentioned talking about avenues for additional psychological support. I'd be remiss if I didn't cover this, but I think for me, what I would suggest to anyone who's open to a clinical team with ITP is to speak to your nurse specialist or any clinician on the team and ask them if specialist psychological support is available. Some hospitals, some trusts are lucky, like ours, to have in-house clinical psychology provision. A lot of them don't. In which case, your best, and in some sense perhaps your only option of NHS free psychological support is a service called Talking Therapies, formerly known as IAPT. They've got a specialist section of their work where they deal with long-term conditions. That's a national group across England. You can go online and Google, wherever you live, and then Talking Therapies, and it will take you to a website with a referral form. You can refer yourself, or you can ask your GP to do it. There'll be some of you sat there probably, if you're anything like every other group I've spoken to, thinking, I used to go to IAPT and they were rubbish. And then for a lot of people, they have had that experience. I would liken IAPT or Talking Therapies a bit like to a GP. For a lot of my clients, the GP is a massive source of support, of stability in their life, one of their biggest strengths. For other people, it's a massive pain in the bum and a huge source of stress and disappointment. You could go to Talking Therapies, get a fantastic service that is really helpful, or perhaps not. But it doesn't cost anything other than time, which I know is valuable, but certainly it won't count against you if you put the referral through, or even if you start work and then say, actually, this isn't for me. So it's worth a shot if you feel like it could potentially be helpful. Thank you very much to everyone for listening. I'm going to stick around during the break if we don't get to any questions now, or if something comes up afterwards, you can come and I'll be sat back there and come and have a chat with me. Thank you.
I found that very, very interesting. Have we got any questions from anyone?
Any questions? I can throw something in. I certainly recommend Talking Therapies. They were very, very useful. Different parts of the country, of course, will vary in their response, but I found them very useful. Everything you've said there, thank you, Doctor. There's a lot of that I have seen and practiced, and there's a lot that we can all do on a very basic level to help ourselves. The first thing is having a plan, I would suggest. When I was diagnosed in 2006, the first thing I did was get a blank sheet of paper and write down what I don't really need to be doing. You'll be surprised, there's a lot more that you shouldn't be doing than there is you should be doing. I realised there were two very simple words in the English language. One is sorry, and the other one is no. Sorry, no, I can't do that. Sorry, no, I can't stand another Spurs match. It will kill me, probably. So those are very basic things, but one thing I'd like to ask about is sleep, believe it or not, because if you can't get the basics right, and sleep is one of them, hydration is another one, nutrition is the next one, and planning, I would suggest they're the 4 areas. And with planning, if you haven't got a plan, then any road will take you to wherever it is you don't know where you're going to. I don't know if that makes sense, but The bottom line is if you haven't got a map, then any road will take you there. So maybe those 4 areas might be worth exploring a bit for folks.
Yeah,
thank you.
I've got very little wisdom to add on nutrition and things like that. Sleep is a big area of psychology. There's 2 main schools of thought on sleep. I'll come back to what I said before, that in some sense all of us are made of the same psychological stuff, right? So there's a lot of commonalities, but there also are key differences, and there's no one psychological model that works for everyone. When it comes to sleep, there's 2 main schools of thought. One is that what you need is a strict plan, rigorous sleep hygiene routine. You go to bed at the same time every day, you wake up at the same time every day, and that's the cognitive behavioural approach to sleep, and that's what you get mostly in places like Talking Therapies. For some people that's brilliant, it's got good kind of medical reasoning behind it, etc. However, for some people it puts a lot of pressure on the idea of going to sleep. For me personally, the worst thing that can happen to my sleep is I start to get anxious about falling asleep. The other school of thought, therefore, comes from the type of psychology I like, which is called acceptance and commitment therapy, and that idea is much more around try and put less pressure on sleep. Go to sleep when you're feeling tired. wake up when you need to, and actually once we suck the emotional venom out of the challenge of going to sleep, we're more likely to naturally fall asleep. There's a really good self-help book from that second school of thought on sleep. It's called The Sleep Book, which I would recommend if anyone wants to take a look at it. And yeah, I would say that as with any of this psychological stuff, you start off with a plan, and then you have a go, and you adjust based on the feedback your life is giving you. And if you're trying that rigorous stuff that you might find on the NHS, and this isn't for me, maybe you're one of the people who would benefit more from this more kind of flexible approach. But I agree, yeah, everything is more difficult on a bad night's sleep, for sure.
Adrian?
Yes, brief one. Thanks, Andrew. That was a super talk. A point that Henrik raised, and it was the issue of shared care, which is something the association has been pushing quite a lot. And we're very used to it as the medical model where the doctor tells the patient what to do. And we've pushed quite strongly the idea of shared care, because I think if you're involved with your treatment decisions, that reduces some of that stress as well, if you feel you're part of the solution of what you're trying to do as well.
Yeah, I totally agree, yeah. I mean, I think it's just another fundamental psychological fact, isn't it? It's like you would do if you were raised a child. People feel invested in decision making, they feel connected to it, and like there's some sort of stake in it, they've got some control. So much of the stuff we've spoken about today, I've spoken about today, and you see cut across psychological topics, is this idea of being in control versus being out of control. It's one of the things that makes feeling overwhelmed so horrible, isn't it? So I totally agree with you, and I'm very lucky in the service I work at. It really does put that at the forefront, and it makes a massive difference. And a lot of the people that I see in my clinic, and we don't just work with ITP, we work with a range of hematological conditions. One of the consistent themes across the conditions is, I came here for help and I wasn't treated well. And not just treated well medically, but treated well as a human being. And that really does undermine people's psychological well-being, regardless of how well their physical health is, for sure.
Super. Thanks very much, Andrew.
You're very welcome. Thanks, everyone.
As Andrew said, he will be around during the break as well, so if any of you have got any questions, just tap him on the shoulder. Right, our next speaker, and she's creeping up on me now, is, as Adrian said earlier, we're pleased now within the association to have the affiliation with the ITP Clinical Nurse Specialist Group as well, and they are now represented on our board as well. So it's great pleasure that I've got one of them here, nurse consultant Louise Taylor, who's going to explain what can the clinical nurse specialist do for you in ITP. Over to you, Louise.
Thank you. Good afternoon, everybody. I'm Louise Taylor. I'm the ITP nurse consultant at the Royal London Hospital. I started out 15 years ago as a specialist nurse supposed to be a specialist nurse in ITP, and knew nothing about ITP. I have a presentation, but I've decided it's boring, so I'm just going to give you the experience without a presentation of what I think a nurse does for the patients. If you want the presentation afterwards, I'll give it to you. When I started out, I asked Adrian Newland to tell me what I needed to know about ITP, because I needed to talk to my patients. He handed me a book about this big on immune hematology. I then went to Dr. Proven and I said, tell me about ITP. And he said, do me a favor, Louise, listen to your patients. Your patients will tell you everything about what you need to know. So I did. And I've realized what a nurse is there for is there to be a bridge between the patient and the doctor. The patient wants to ask so many questions from a doctor. The doctor has limited time to talk to the patient. I have more time, so I can be there, and I can be there to answer questions. If I don't know the answer, I'll go and ask. But over the 15 years of being the ITP nurse specialist and the ITP nurse consultant, I can argue the toss quite nicely with all of them. And I am there to bring the patient's concerns to the doctors. I am there to help the patients decide what medication they want, what they want on their ITP pathway, what their concerns are. I listen to them. I become part of their family. They phone me and they say, I don't feel very well. I ask them questions. I'm there to control their anxiety over their platelet count. I try my best to treat them and make them sure that they do not need to worry about their platelet count. As Drew says, his first question to the patient is, oh, your platelets are lovely. How do you feel? My question is, how are you feeling? And they say, I'm feeling very well. And I ask, have you got any bruising or bleeding symptoms? No. Have you had anything like that in the last few weeks? Then they say no. And then I say, oh, that's amazing, because your platelets are 12. And they go, oh my God. And I say, what are you worried about? You've got no bleeding symptoms. And I manage the concerns. We go to MDTs and we sit there and we try and work out what we're going to do for the patient. And because I know my patients, I can say, this patient will not tolerate these drugs. I would suggest we look at these other drugs. I then go back to the patient after the MDT and I say, we've discussed the following drugs. Let me discuss these drugs with you, give you all the information that I have. You go away and think about what you want to go and do further. The other thing is, the patients come to you and they say, I've been on the internet and they're telling me I'm going to die from bleeding and things like this. So I have to explain that ITP, although it is a bleeding disorder, it's internal, under the skin, you're not going to cut your arm and die. You stand more chance of crossing Whitechapel High Street and being hit by a bus than dying from ITP. You've also got to explain to them that intracranial hemorrhage is a minor, it's a worry, but it's a minor, it doesn't happen very often. So you've got to manage their death expectations because they think they're going to die from ITP. So you are there to manage expectations. You are there to guide them to different areas. You are there to look after their family as well. Because some people's family, the parents of adolescents will come and they panic more about what's going on with their child than the child is. You've also got to give directions on where they go, how, what to do, what activities to go on. My reasoning, and every doctor here will come and moan at me, I say, do whatever you want to do. Your body will tell you when your platelets are low and you will not feel like doing what you want to do. You don't go bungee jumping. If you're going to go skiing, please tell me you're going skiing so I can organise IVIG. Please. And I'm there to manage all the emergency treatments. I'm there to organise their tests. I'm there to answer their questions. I'm there to tell them what next steps. And they're there to talk to me every day and ask me, give me their concerns. So we're also there, we can direct them to various other areas. I manage the sickness, the pregnancies, we deal with pregnancies, we manage the treatments of the pregnancies, we manage the setting up their surgeries, so I have to optimize the platelets and everything. The doctors don't have time to say to you, to the patient, well, we've got to get your platelets right, so we've got to juggle your surgery date on such and such. That's my job. My job is to liaise with the patient to find out which dates are going to suit them for their surgery so that we can optimize everything. I give them all the information, they take it away, they come back. The biggest one is always, which TPO shall I take? So we go and we discuss their lifestyle, we discuss do they like injections? I can convince them to have injections. I can train them up to have the injection. I can find out their lifestyle. Most of the younger people like going out and getting drunk and disorderly and forgetting that their old tromba pack shouldn't be taken with their kebab and their protein shake in the gym. So you guide them to what the best medication. You don't tell them the best medication for them, you guide them and they make the decision. When they are down because the treatment is not doing what they want it to do, you build them up and you remind them there's other treatments. But then there is the patient that is refractory to every treatment, and you've got to talk to them and listen to them. And sometimes you've got to make a decision with the patient to stop the treatments, watch and wait, and learn to know their body. Does it bleed? If it's bleeding, we'll treat it. If it's not bleeding, let's wait. So everything and anything is about asking the nurse, me being the advocate for the nurse, and sometimes being the advocate for the doctor and telling the doctor to calm down, or the doctor says to you, I've got a trial, and then you go, the patient is very busy. I'll get him to, I'm quite convinced I can get him to do your trials. So I also have to recommend trials to the patient. So basically, in short, even though I'm early so that I can answer some questions for you, is the nurse is there to bridge everything from caring for the patient, looking after the family, delivering babies, healthy babies, bringing up adolescents from, because I'm a pediatric nurse, but I'm also an adult nurse, but I look after the adolescents. And sometimes the adolescents are harder to look after than the adults, the parents, or the babies. So it's also changing the appointment times to suit the adolescents and working out our clinics and everything. And you can only do that if you've got a very good team. So we've got a very good team and we actually work together. We can juggle things. And in our hospital, we can actually add people into our clinics. We don't mind the odd overbooking, so we don't mind a walk into our clinic. So I am on the phone 4 days a week. And the patients have got a telephone call to me and they can talk to me anytime. They've got my email. I tell them I won't answer it over the weekends, but I will answer them first thing on a Monday morning. So it's knowing who you can approach, knowing all the contacts, knowing all the emergency numbers, handing out the information of the ITP Support Association so they can also find that there's different people. And it's introducing your patients in clinic to other patients that have ITP. And they'll sit in clinic while they're waiting for you and have long gossips about their different treatments. And then they'll come and say, but that patient got that. And then I say, yes, but that's not quite suitable for you. Why not? And you explain. So, in conclusion, if you want me to go through the presentation, I can do that. Have you got any questions that you want to ask me? And the only thing is that I'm going to have to put a hearing aid in. Sorry.
Anyone for any questions?
Sorry. could put a hearing aid in, otherwise I will never hear.
Hello, Louise. First of all, main question, can you move to West Yorkshire?
I'm sorry.
Thank you. Can you move to West Yorkshire?
Yeah.
I've had ITP over 30 years. And in the beginning I saw...
Can you move to West Yorkshire?
No, I can't move to West Yorkshire, but I'm on the phone. You can phone me. You can phone me. The ITP Support Association has my telephone number, my email addresses. You can phone me.
Can you hear me if I stand up?
I've got feedback on my hearing aid.
Yeah.
I've also got hearing aids in as well. Can you hear me now?
Sorry?
Can you hear it now?
No, I've got feedback. Sorry.
Second question after you.
Right, no, the first question was, can you move to West Yorkshire?
Unfortunately, no. I do love London.
In 30 years, I've never met anyone like you. And we have no one in between myself and the haematologist. We do have now. However, I was approached by the haematologist about 15 years ago and told that because I didn't have any of the symptoms than a low platelet level, really I needed to go away because other people could have that appointment. And I insisted that I still had an appointment. I asked, could I take over 15 minutes of your time every 6 months? And down. So now, after 30 years of having ITP, I see, I don't see them. Someone phones me every 12 months, briefly asks me how I am, gives me my platelet number, and that's all I get in 12 months. No one like you or anyone else speaks to me about ITP, other than what I get from the ITP Association.
That is the biggest problem in areas that don't have an ITP nurse. I work with Dr. Chen and Dr. Proven and 2 other consultants. I am in the clinic, I see my own patients, but I am invited to meet every single patient, and every single new patient has a booking to see me on the same day of the first day that they meet the doctors. So I generally will spend about 30 to 40 minutes talking to patients, and then weekly after that, just to make sure that the patients are getting the needs and their psychological needs and their expressions of interest and whatever they need to do. So that's what the nurse is there for. She is there to spend more time to look after the patients. I would go back to your patient liaison groups in your hospitals and ask them to consider getting clinical nurse specialists for clinical haematology. You will never ever get a single ITP nurse, you'll probably get a joint nurse, but the clinical nurse specialists have all the same training, but they don't have the specific ITP training, but we are working on training up a lot of nurses. So we have lots of programs for nurses to try and get a nurse into every single hospital.
Any other questions from anyone?
Anybody else?
Thanks for what you do, Louise. That's great. Is one of your jobs to read the doctor's handwriting?
Sorry, what was that?
Is one of Louise's jobs to interpret the doctor's handwriting?
Is one of your jobs to interpret the doctor's handwriting?
They are not everything nowadays is on a computer.
Really?
But I trained in the olden days where you could guess what they were writing. So one of the greatest things in medicine, which is also a hindrance, is our computer system. So everything that you do on a patient, you document. So the doctor that comes after me knows my plan. Everything that we do in the MDT is on there. And so hopefully they follow what we decide for them. A lot of psychological work is caring for their chronic fatigue, getting them ready to have all the treatments and everything, and discussing the side effects of drugs and listening to the side effects of drugs, and sometimes having to change the drugs. So, if anybody, please ask Mervyn for my things.
Thank you very much, dear. Thank you.
Thank you.
This is high. Come hold me down.
She always gives me trouble every time, but anyway. Right, the next speaker is a lady, Professor Nikki Cooper, and before we call her up on stage, there's already been one white smoke moment earlier this week with the announcement of the new Pope. Adrian and I would like to announce as well, Nikki has agreed to become a trustee of the ITP Support Association and join their board. She's already a medical advisor, but welcome, Nikki. Thank you very much for having faith in us. Thank you. Right, I'd now like to invite up Professor Nikki Cooper, and Nikki is going to be interviewing one of our young patients. Ella, where are you? There she is, yeah. Ella-Sophia Ellis is also one of the EHA Young Patient Advocates that we nominated last year. She's also a young patient observer on our board, and Nikki's going to interview her. Thank you, welcome. Do it till 3 o'clock.
Thank you. Hello, everyone. Nice to see you all. And I guess, first of all, Ella, thank you very much for coming and sitting up here, because it's quite stressful, I think, doing these things, isn't it? And first of all, you just need to answer what you're happy to answer, and obviously if you're not happy, then we can move on. So the first thing I wanted to ask you is just if you could be happy to share your story with everyone here.
And just say, thank you so much for this opportunity, and I'm really looking forward to it. So, my name's Ella Ellis. I was diagnosed with ITP when I was 9 years old. I'm 26 now. So that was back in 2008, 2009. I can remember the day so clearly. I had difficulties with another illness that I'd had, chilblains, randomly, and they'd asked if I that I wanted to go for a blood test, and obviously my parents had agreed. Before that, I'd always had bruises, really quite bad, to the point teachers had asked about why I had bruises, and that had obviously really concerned my parents. And then it was a Friday evening, and that night sort of changed the trajectory for me for obviously many years to come. I was taken to hospital and went through plenty of tests and was diagnosed with ITP, and then the journey kind of went from there, really, from my local hospital to Birmingham Children's Hospital to Manchester Great Ormond Street. And it was a real journey. I had chronic ITP, I had very severe bleeding episodes, everything from sort of nosebleeds to internal bleeds. I really, went through the ringer, really. Going through the medicines earlier, it's a real reminder of the medicines and the treatments that I've gone through, all the way to sort of splenectomy, included in that. Around 16 was sort of the taper end of my sort of ITP for that portion of my life. But then, unfortunately, as I've sort of discussed with quite a few people today, I was at University of Sheffield, and I'd long forgotten about ITP. That was a thing of the past. Hadn't even brought it up to any of my new university friends and my new social circle. And then I was on my way to a concert, and I looked in the mirror, and I could just see a bruise descending on my face, and I just thought, I know what's going on. And it was my best friend. She had no idea that I'd gone through this when I was younger. Hadn't wanted to mention it. And then again, I'd relapsed, and I relapsed quite severely. For a few different reasons, I ended up in ICU at that point. And then again, taper end of that, after a few years, got better. And then I'm kind of here now, really. I'm really happy to say that I have a good platelet count for now. And that's a really, I guess, plotted history of my ITP. I hope that's useful.
I guess things I think might be helpful for people here is what were your coping strategies? You know, thinking about the excellent psychology talk we just had now, how did you handle, was that talk helpful for you, and how did you cope with that kind of stress bucket and things, I guess?
Thank you. That talk was really, really useful, and something that we spoke about over lunch, a treatment that wasn't mentioned. It's not a treatment that can cure ITP, it's not a treatment that can necessarily bring up your platelets, but probably one of the best treatments I had when I was younger was psychological therapy and CBT therapy, and seeing a counsellor at the time. And I had mentioned this to you, I must have been about 11. I was like, why am I having to go to another hospital to see another person to talk about life with them as well? But I can look back now, and after many sort of sessions that I'd had, and I can remember the lady clear as day, that really, really helped, and that set me up, I think, especially then for the relapse that I then had later on in life, and going through those therapies and thinking about cognitive behaviour therapy and how that can help. So that, for sure, definitely, I cannot think of life with ITP without that treatment as part of what I went through. Support system as well, I would say that, again, something we spoke about, while this is my own illness, my parents, I almost associate the illness with them so much, especially my mum being my primary caregiver. It feels like the illness is an extension to her as well. She was a huge support system while I was in hospital there, every single treatment day, hospital appointment. It was mentioned earlier, actually, sometimes how often parents are actually the people that can worry over the adolescents. And I guess just social networks, and then I would say later on in life, keeping active. Obviously, we've heard quite a lot today about the importance of holistic health and being active, looking at your microbiome, nutrients and sleep. All of those things are super important, and something that I just consciously now always keep in mind as I I'm fortunate to be in the space that I'm in.
Is fatigue a part of your ITP? And if it is, how do you manage that? Because I think one of the things I think sometimes can happen if you're tired, you stop exercising or stop seeing friends. How do you kind of handle that part of things?
Yeah, no, that's a really good question. Fatigue is definitely, I think, for most people with ITP, part of their things that they suffer with. And I think particularly when I was younger and I was at school, at the time I was doing, must have been my GCSEs, that was really, really difficult. And I honestly, I don't know if there's a quick answer I can give really on how to manage that. I think, again, sort of pulling on your social networks, family, and, where you can have that support. Obviously at the time I was younger, so, it was my mum who's making my dinners for me, so that's all right. But, things like that, having support from family and friends, them understanding, if you have to say no, pull away from activities, and people advocating on your behalf as well. I'd say moving it into the context of, being an adult and working, having an understanding employer, having those conversations. I'm very, very fortunate in the job that I'm at now, where I've had those conversations with, my managers that I've had and colleagues, where I can talk to them about how I feel. So ITP is a roller coaster. There's often people think of illnesses as having a diagnosis and then upward trajectory, and I always found really difficult with ITP that is not the case. It's not the case with many chronic illnesses. It's up and down, having to really explain that and having people that understand that fatigue can be fine and then it can not be okay. I think just talking about it as much as possible and finding support.
You're incredibly well adjusted, and I think that's you, but did you think that psychology support at the beginning has helped you to sort of manage some of that? And if so, I think for teenagers it can be quite hard to convince them to do something that you think they might be benefiting from, but they say no. How would you recommend that we as adults kind of can communicate that to sort of teenagers or young adults who don't want to do something that might be beneficial to them?
Thank you. Yeah, no, that's a really good point actually, because I think at that age I was probably young enough for my parents to just be like, go see that psychologist. But yeah, it definitely, I think, as you maybe get into those teenage years, and it was just the last thing I wanted to think about, although it was such a massive part of my life. I just thought, no, like I want to go out with friends, like I don't want to have to go to another hospital appointment. So I had that kickback really. So I think, you know, when it comes to any sort of treatment plan and maybe young adults and teenagers, empowering them, talking them through the benefits, the side effects, and being honest with them about the negative impacts, but just really at each point, yeah, just empowering that person, so it doesn't matter if you know what age you are, that they're making those decisions about their illness and their treatment plan for them. It would be very important. And yeah, I think really now, you know, that there's, as we've seen with a lot of the talks today, you know, whilst it might be focused on specific, you know, platelet treatment, interwoven in that more so than ever now, are people talking about mental health and the importance of having quality of life as well. I'm sure anyone that's had maybe ITP, chronic illnesses for spanning decades, has also seen that conversation move forward, that it's just mentioned so much more now, so I think it is more acceptable and people probably would be more open to going something like therapy, for example.
What made you become an EHAR young person's advocate?
Mervyn emailed me. And so there's a really, well, he actually emailed my mum first of all, because it was a bounce back email. I'm very sorry about that, I don't know what happened. And yeah, I saw the opportunity, and it was just really exciting really. And I think the opportunity as well, just to connect with other patients with haematology illnesses, you know, anything from sickle cell, haemophilia, leukemia, that has been such a profound experience. You know, it brought me to tears when I went on the first trip, and I think a lot of the other young adults who attended as well felt the same, that it was just so really quite overwhelming to join such an amazing group of like young adults that are just doing so much as well for their own organisations alongside dealing with their illnesses. I think to answer your question, for me, now that I'm in this state of remission, and you know maybe that will look like in a relapse in years to come perhaps, I feel that I'm in a space where I have the privilege of a good platelet count, and you know limited on you know any side effects of ITP, so I should pay it forward. You know, I think about my parents joining the ITP Support Association when I was 9, and the solace and gratitude that they have towards the organisation and what it meant for them. And if I could be that person, for my family, could be, you know, that support network for other parents, young adults, anyone that is going through ITP, it can be such an isolating illness, then that's my motivation really. And yeah, to come and do cool stuff like this really, and talk.
And I think another thing that can be quite difficult is being an advocate for yourself. So we all know how stressful the NHS is, how short a time period you have with a doctor. Are there any clues or help you can give to people how to deal with your doctor if you don't feel like they're listening, or they're not quite sure, you're not sure that they've heard you? Have you felt that, and is there any sort of ways that you think you've helped to deal with that perhaps people can think about?
Yes, I've felt that. I've had the misfortune. I've gone through a lot of different sort of care systems as I've gone from childhood ITP to then university ITP, where I was at a different hospital, and then to where I'm at now. And amongst that, the most incredible NHS staff, incredible people that I've met. Equally, you know, doctors that are quite persistent and sometimes don't hear what the patient wants. I think especially as a child as well, and a teenager. And particularly through that university stint where I didn't really know what was going on. ITP was, again, something that happened as a child, and I thought, I don't know, what is this? It was like a new disease all over again. But I think through support networks like this, are incredible, because you can talk to other patients. I mean, Diane has been so helpful in helping me navigate, you know, being in Manchester, for example, and looking at, you know, the hospital system that's here, which is different from back home for me. So having support networks, and I think empowering yourself with knowledge, but then not too much as well. I spoke earlier with someone about TikTok, and that there's lots of information on TikTok that can be a bit overwhelming. But I think just empowering yourself with knowledge about your own illness, knowing what works for you, and just really maybe having someone there with you at appointments. That was obviously something that I had with my parents, and something that they try and continue to do now when I go for my follow-up appointments and things like that. But yeah, I'm an advocate, poster child for ITP Support Association. I would say that is a very, very, very important for so many reasons in being able to advocate for yourself through, you know, doctor's appointments and all of the sorts.
And then finally, you've got some doctors in the audience here, and quite a lot of us do a lot of education for ITP. What would you recommend to doctors as to how to deal with young people or anyone sort of with ITP? What kind of skills do we need to learn better?
Thank you. But this is actually a conversation that we had at the EHA last year with the young patient advocates. A skill I would just say, as I say, I've had really overwhelmingly positive experiences, you know, with my treatment throughout all the different sort of jurisdictions and hospitals that I've been at. But I think being inquisitive about that person, I know that can be very difficult and people are very busy and tight for time, but I think making it really personal, that's something that I've experienced most recently, it felt like my consultant really cared about what I cared about, how ITP affected me. We all have different lifestyles, different things that we get up to, you know, outside of work, or what we do for work, or what matters to us in terms of activities. And I think taking that really personal approach, because then that can have an impact on treatments that you have as well. So, you know, for example, if you're a young child, it might not be feasible that you go in for quite lengthy treatments in hospital where you have to stay there for a number of days. You know, thinking really personally about that person's lifestyle and what would work for them. I think that's pretty important, and I would say, you know, I would ask that doctors, physicians think about making it a really personal journey for that person.
One of the things that came out of we've done some work to try to create a book for teenagers who get ITP. And we did a lot of chatting to teenagers about it. One of the things I was quite struck by was how important it was for the 16-year-old to be offered either an injection or a tablet or something else. But that really came out that was really important for her to be able to make that decision. Does that strike a chord?
Yeah, no, definitely. I completely can understand where that's coming from. It might sound really minor and, you know, it's the same treatment, but it really is, you know, again, it comes down to that person's lifestyle and what they know works for them. So definitely just that empowering the patient to make those decisions for themselves is super important. I agree.
And is there anything else you'd like to say to everyone?
Just, I guess, thank you for this space and holding this space for us to have this conversation. And yeah, thank you everyone. I hope you've enjoyed the day as much as I have. This has been brilliant. I've really enjoyed it. I've asked so many questions, and I guess, you know, we'll have a break in a bit, and I implore people to go up to all the very smart people in the room and ask them questions. I've taken full advantage of that, and thanks everyone for sharing this space. Thank you.
And thank you as well. So thank you for sharing your experience with us. And I agree with Ella, just do come and ask us. Don't be afraid to come and talk to us about anything. So thank you very much.
Right, we won't have questions on this bit. If there is any questions you've got, we can ask them at the Q&A. But tea and coffee is available upstairs. We've got 15 minutes, so we want to come back here at 15:15, please.
Just a very quick thing to throw into the mix. We were talking about fatigue. If you haven't seen it, we've got some very good presentations on our YouTube channel on fatigue and quality of life. So do take sort of half an hour to have a look at them when you get back. Get yourself a coffee and have a look at them. You know, they're very useful. You find that they're very practical.